Hello everyone, welcome to this audio podcast. In this series, the SZ Loci Equinox. This is the scientist, and I'm going to provide sort of an overview surrounding this, an overview in this audio podcast surrounding IgA nephropathy or IgAN, and this is another another sort of collaborative between the RPSG and KDARs and aligned to another ZtormLabostix production. So in this sort of audio podcast, I'll be providing I'll look to highlight some context in and around IgA nephropathy. Some bases around the epidemiology around IgAN, and sort of the pathogenesis and the sort of symptoms, the sort of clinical manifestations, and in context of pathology medicine, sort of some of the sort of an overview excuse me, in context in and around sort of the biomarkers that can be used as part of the sort of workup around IgAN, and then I'll look to highlight some aspects around the sort of IgAN and disease progression, and also sort of the treatment strategies. In this audio podcast overview, there will be a sort of a list of sort of material, if you like, where basically listeners are more than welcome to check out the sort of material for further information around IgAN as well. So to begin with, IgAN or IgA nephropathy is also or has also been referred to as Berger's disease. Recipients can present with a range of signs and symptoms from asymptomatic microscopic haematuria to macroscopic haematuria and or proteinuria. It is perhaps one of the most common forms of glomerular diseases or glomerulonephritis, glomerulonephritis, pathological sort of diseases that have been documented sort of globally and associated with where there's poor prognoses, or it can be poor prognoses, and resulting in end stage renal disease or ESRD. And IgA is at a sort of from a immunological basis. IgA forms one of the main parts of the immune system, where it's linked to complement, and IgA deposits are also associated with other sort of systemic diseases, such as, for example, Henoch Schönlein purpura or HSP. And susceptibility to IgA and risk of disease progression are influenced by by a confluence of genetic and environmental factors. Sort of the epidemiology, if you like, now. So the prevalence varies geographically and estimated of disease impact or burden can vary accordingly, and really the basis the basis around IgA or IgA nephropathy have been evidenced through nephrology based registry data, and it is a common cause of different it's a common cause in and around as a form of chronic kidney disease or CKD, with overall incidence of about 2.5 per 100,000 individuals. Epidemiological investigations have demonstrated that the incidence is increased in individuals of Pacific Asian origin, and in up to around 50% of IgA and nephropathy recipients, the disease progresses to end-stage renal disease within 20 to 25 years of diagnoses, or part of diagnoses. And IgAN more frequently occurs in males than in females, and usually affects those in age populations and age range and groups between 16 years and 35 years of age, which account for approximately 80% of total recipients. In relating to the sort of pathogenesis, so this disease occurs with immunoglobulin A, or IgA, and where IgA deposits in the kidneys or around the kidneys lead to the development of local inflammation and renal injury, and considered as an autoimmune disease with a multi-hit hypothesis that have been evidenced around IgAN. And so one of the first hits around this is there's the production of galactose deficient IgA type 1, and it plays an important role in the formation of immune complexes. The second hit around this is that there's a production of IgG, immunoglobulin G, autoantibodies which target the O glycans in the hinge region, and also leading to the formation of immune complexes. And so these complexes induce local inflammation, and this leads to the activation and mesangial cell damage ultimately. And the antibodies involved in IgA pathogenesis can include GD IgA type 1, anti-glycan autoantibody, and C3, and here is a sort of an overview in a sort of a schematic highlighting the interaction between cytokines cytokines, for example, IgG and IgA type 1 antibodies, autoantibodies, as well as the sort of formation around immune complex formations. Um, uh, in a sort of a broad sort of a way, IgA nephropathy can be looked at from a pathology and sort of clinical medicine basis by investigations through, for example, looking at protein leak in the urine, where there can be pain in the abdomen, where there can be evidence of renal insufficiency or acute kidney failure, and also blood in the urine, or hematuria, and evidence of, for example, hypertension as well. So the sort of clinical manifestations that are aligned to those sort of pre sort of ponderances can include where there's a range of clinical manifestations around IgAN, where individuals or recipients can be asymptomatic in some contexts, since if for example, where hematuria, for example, can be evident, however, from a preliminary stance, the hematuria and can be identified as asymptomatic, wherein the hematuria is almost asymptomatic, wherein the hematuria is microscopic, and thus rapidly sort of progress and becomes progressive, leading to glomerular damage, or glomerulonephritis, and as part of the diagnosis in relating to IgA nephropathy. And the sort of common phenotypes, so the two most common clinical presentations are, again, sort of where there's asymptomatic hematuria and sort of progressive renal damage. There's asymptomatic hematuria with sort of minimal proteinuria of less than 5.5 grams per day, and it may be detected through screening, through screening, and there's alongside the clinical manifestations, there can be isolated microscopic hematuria with minimal proteinuria is regarded as part of a sort of a favorable as part of a favorable prognosis. renal the renal tissue kind of sort of has So in related to the biomarkers, as part of the sort of diagnoses, a renal biopsy tends to be or has been sort of one of the gold standards for diagnosis and assessment of disease activity and prognosis. And GD IgA type 1 or 1 is as a biomarker is increases in blood and urine in recipients with IgA nephropathy, and the same biomarker in the serum of recipients with IgA nephropathy have been identified within the immune complexes bound to IgG and or IgA 1 antibodies, and several levels, serum levels of IgA1 as specific IgG autoantibodies are correlated with disease severity as well. Increased serum IgA1 levels are associated with proteinuria and a greater risk of deterioration of renal function in IgA and have been evidenced in the literature. Combination of high serum IgA1 levels and levels of advanced oxidation protein products is correlated with a more rapid decline in and around estimated glomerular filtration rate as well. So, of course, one of the main things around IgA nephropathy, for example, FSGS, and sort of other forms of sort of renal pathology, where the main aim is to sort of retard the renal damage. In IgA nephropathy, there's several sort of approaches. So corticosteroids and immunosuppressive drugs can sort of dampen the immune system and stop it from attacking the glomeruli. ACE inhibitors and ARBs or angiotensin receptor blockers as antihypertensives can be used to reduce and sort of offset the protein loss alongside hypertension, and there's also there's evidence to indicate that certain lifestyle aspects can be helpful as well, and so the literature around this around IgA nephropathy, again, like that of FSGS, and like that of FSGS, have similar bases in relating to slowing down or retarding renal damage. The treatment strategies are several, sort of more specifically. So conservative therapy is to reduce proteinuria and slow the rate in context of renal function, and corticosteroids can be used to reduce proteinuria in IgAN, and studies have evidence that exposure to corticosteroids for a 6 months duration may have something that's been referred to as a legacy effect, with sustained reduction in the risk of progressive renal insufficiency. Aligned to sort of immunosuppressives, mycophenolate, for example, data has highlighted that regarding the sort of efficacy of mycophenolate, there are generally the guidelines have varied, but generally there's more owing to sort of advances in immunosuppressive agents. For example, mycophenolate for IgAN has not been sort of a main based recommendation. Current guidelines recommend against use of mycophenolate for IgAN. Rituximab in several investigations studies non-effect on there's been little or no effect of proteinuria on proteinuria and renal function with rituximab as a monoclonal antibody. And combination therapy in literature has been identified as generally reserved for recipients with progressive disease, and in treatment of IgA nephropathy, and recipients demonstrate has been highlighted and demonstrated that there's been an improvement in renal prognoses post 2 years receiving sort of combination therapy. And I won't delve into the detail, but at the end of this audio podcast, there will be there's and that does bring us into that onto that, and so there's in this list, there's a few sort of references relating to relating to IgAN or IgA nephropathy, and works these works, the works around these can be put into a search engine, and hopefully if listeners are intrigued, then they can and should be able to access the full papers to find out more about some of the updates around IgA nephropathy by doing that. And so once again, a few acknowledgements where this work has a collaborative between RPSG and KDARs as a collaborative and aligned to a ZtormLabostix production. And so there's an academic collaboration alongside the RPSG and KDARs as well. Once again, thank you for taking the time to tune in on this audio podcast around IgA nephropathy, and this has been an audio podcast aligned to the SZ loci equinox, and this has been the scientist, and it's another ZtormLabostix production. Thank you.